blood flow, you are creating pre-renal failure. So vasoconstriction is not good. One of the other ways, these myoglobins, they when they are a lot, they form stones, which tends to obstruct the proximal convoluted tubule, and these combined, they cause AKI, acute kidney injury. There's let me introduce you to a new term called pigment nephropathy. Pigment nephropathy. Pigment nephropathy is kidney damage secondary to molecules that are said to be pigments or pigmented. So those pigment molecules that we know in the body, one of them is hemoglobin, the other one is myoglobin that we have just spoken about, and I almost said talking about. Okay, it's fine. And also bile. So these are our pigments in the body. So when they are in excess, they've got the potential to cause what is called pigment nephropathy. The pigment nephropathy in question is myoglobin. So we're talking about myoglobin pigment nephropathy in this case. So whenever you think about crash syndrome, just think about pigment nephropathy and start to think how these pigments cause nephropathy. Okay, so like I said, whenever you see a patient that has got extensive bruises in the body, especially in the major areas that have got big muscles, the back, the abdomen, the thighs, think about rhabdomyolysis. So you will examine the patient, HLS principles, but the way in which you diagnose, it will depend. When do you see the patient? There are patients that will be assaulted, go home, or be found a couple of days later. They come, bam, they already have renal failure. Or when they come, they are still fresh, but the fact that they've got bruises everywhere should make you to, as much as they might have a few lacerations or maybe fractures, as much as you're gonna treat the fractures and all of that, but you wanna keep them up until their CK is out and give them fluids while you are waiting. But there are things that you can do to sort of like check if they might have rhabdomyolysis. So one of the things that you can do a urine dipstick. You can first check the color of their urine. Macroscopically, you might just see that it's coke-colored or color-colored, right? No, that would be, you don't need a dipstick to see if the urine is coke-colored or what. So you can just look at that and then you do a dipstick, urine dipstick. There will be blood because of that globin, and then they will also have protein because of the globin as well. So because of the myoglobin, they will have blood and then they will have protein in the urine. And then you can do then you do your serum CK, do your UNEs. So when you do CK, you want to know how much is the CK in the blood. Then that will give you a diagnosis. That will tell you. The CK is very important to diagnose rhabdomyolysis. I'm tired, guys. It's 12 o'clock. So the UNEs, you look at the urea. Look at the urea. look at the creatinine, because if the patient is already in renal failure, these will be high. Your urea will be high, and your creatinine is also be high. So once you've got any of these deranged, then it means you've got AKI already. You want to know that. As you do your UNEs, don't forget to tick potassium there. Another thing that you can do a quick ABG, because if you are waiting for blood and you've got a patient that has got hyperkalemia already, your ABG will help you to tell if you've got hyperkalemia. Some people say, while you are doing the ABG, just connect the patient on the ECG and check if they've got hyperkalemia changes, like your broadened QRS complex and your peaked T waves and all of that. So this is how you can diagnose rhabdomyolysis. Those who come in already with kidney failure, yes, they will have oliguria, anuria, and things like that. So now, how do you manage these patients? Obviously, depending on what other injuries do they also have. So take care of those injuries as well. If they've got a fracture, splint it, and all of that, go an X-ray and see the fracture, splint it, put a back slab, give analgesia. If everything else is fine, so you give them good analgesia, and you make sure that you give them fluids. Doesn't matter whether renal lactate or normal saline at this point, as long as you're going to be giving fluids, because when you give them fluids, you are trying to flush all of this myoglobin that is in the kidney, and you're trying to make sure that you flush the kidney so that if there are stones that are trying to develop, you can flush them out. And we said that they get vasoconstriction. So if you've got vasoconstriction and you already have hypotension, that kidney is going to die, because you've got two factors that contribute to a pre-renal failure. Vasoconstriction, that is, we know that is caused by myoglobin and its metabolites. So if you give enough fluids, even if you've got a little bit of vasoconstriction, the kidney will still be perfused nicely. Then you're flushing the stones and making sure that the patient is hydrated, because once they've got hypotension on top of everything else, the AKI will just be more pronounced, right? So I've had a patient that have complicated from this rhabdomyolysis. So when he came, he already came with that was the day after he was assaulted. So he already came with a urea of 40 and a creatinine of 800 and something. So his urea was 40.1 and creatinine was 821. So already this patient has got renal failure. So me giving him fluids, I was going to push him into pulmonary edema and initially lose him. So I had to be clever with my fluids. I gave him fluids, but I had to discuss this patient with internal medicine for dialysis. So after the fluid management, if that does not work, the patient's got AKI, the next thing now you have to look at is dialysis. And another thing, with the CK, it takes about 1 to 2 days to peak, to go up, and at about 3 to 5 days it starts to go down. It takes about 1 to 6 hours to increase. Between 1 to 2 days it has reached its peak, and then from 3 to 5 days it starts to go down, right? Some people say 1 to 4 hours. So if you do it, check when was the patient assaulted. If they come in within 2 hours, within 3 hours, they still have a normal CK, you rather repeat that CK again just to make sure if and look at the trend. You will compare the CK that you did when they came and then the CK that. So the best thing is to admit these patients and discharge them when the CK is out. When you've seen their CK, when you've seen, if you are really suspicious and worried, keep them even for 2 days and get at least 2 or 3 CKs that are about 6 hours apart, 8 hours apart, and just to check while you give them fluids, and make sure that they've got a catheter to monitor their urine output. And yeah, so when do you consider dialysis? So when do you dialyze these patients? Dialysis. So if they've got hyperkalemia, especially if it's not correcting or it's recurrent, some would say let's try and shift and see if the patient will be fine. But hyperkalemia is an indication for dialysis. If they've got fluid overload, if they've got anuria, because if they've got anuria, the more fluid you give, they will get into pulmonary edema and they will die from the pulmonary edema. You can also send them for dialysis if they've got like massively increased CK, right? Yeah, the reason why I sent my patient, I just got a nice MO that I referred my patient to. The reason why I referred him, I was worried about the urea that was 40.1 and the creatinine that was 821. Even though the patient was passing urine, but this confirmed renal acute kidney injury and renal failure for me. And also, yeah, one thing I'm forgetting, his GFR was about, I think it was about 12 already. So that's why I referred him. So guys, I hope you enjoyed that. I'm so tired. I hope I did justice to the topic. Thank you.